Good afternoon, ladies and gentlemen, and to all our audience. My name is Mary Vic Aplaan, and I'm one of the counselors here at the and recreation therapist here at AGI. If this is your first time with the Alzheimer group, we are a charitable organization that supports families and individuals living with dementia. Some of our services include individual and family counseling, support groups, activities for people living with dementia, and educational workshops. So this lecture is made possible by generous support of the Lassner Learning Center and the Lindsay Memorial Foundation. Today we are lucky to have Dr. Marie Lee Hughes, and she'll be talking about the palliative and end-of-life care for persons living with dementia. So Dr. Hughes is a postdoctoral fellow and instructor in the School of Nursing at McMaster University. She is a recent award recipient of the Alzheimer Society of Canada. Her interest in dementia care is inspired by her many years of experience as a registered nurse, supporting persons living with dementia and their families in a long-term care unit. She is passionate about pursuing research to support the meaningful engagement of persons living with dementia and family and friend caregivers. So we would like to thank you, Dr. Hughes, for your time. Also, we welcome the audience to feel free to write your questions in the Q&A right at the bottom of your screen and during the lecture, and we will have the question and answer period at the end of the presentation. So again, welcome to the lecture, and again, welcome Dr. Hughes, and the floor is yours.
Great. Well, thank you so much, Mary Vic. Am I pronouncing your name?
Yes.
Okay, great. Well, thank you so much, everyone, for joining. Apologies for the delay. There were some technical issues, I think, on both ends. So thank you so much, everyone, for being here today. So I am much looking forward to talking about palliative and end-of-life care for people living with dementia. And I have a small PowerPoint that I'm just going to use. Can I have screen sharing function, Mary Vic? Okay, can everyone see my screen okay? With the slides? Yeah, okay, great, okay. Excellent. Okay, so I have a little bit of an agenda of what we're going to be talking about. I was hoping to have a bit of a spontaneous discussion, or as questions get asked, if people are comfortable in putting in their comments in the chat box, and then we can take up the comments there. So I'll be starting off with a bit of a broader discussion about what palliative care is and what it means for you. And I think that's really important to think about, because it's a unique definition and everyone defines it differently. I'm also going to talk about some of the goals of care decisions, and I have here in my agenda, it's really for information purposes. I'm not here to sway anyone in any direction or to say, you should be doing this or you shouldn't be doing that. So it's just more for insights and just sharing some of the risks and the benefits and some things to consider further down the line. I'll also be talking about some of the common care decisions at the end of life, and these are not decisions that you will be making alone. It's in collaboration with the healthcare providers and also with your other family members as well, who are part of that circle of care. We'll also talk about having a little bit of a discussion on grief and feelings of loss throughout the journey of supporting someone living with dementia. Okay. Yeah, so a reflective question. I was wondering, what does palliative care mean to you? When you hear those words, what are the first things that you start to think of? And if people are comfortable in putting that in the chat, that would be great. And I don't know if I can see the chat function actually. So Maravek, if you're able
I
to let me
haven't
know.
I haven't seen any
Not yet? Okay.
Yeah. So
Okay. Yeah, so feel free to take your time, think about that. On the next slide, I'll provide a bit of a definition of how palliative care has been defined now, and the the definition will evolve with time. This is what it looks like today, but it might look different later on.
Hold on. There's like 4.
Oh, the chat is disabled. Okay.
Oh, okay.
But I do see some, Joanne, you've mentioned pain management is important part of palliative care. Absolutely. It's important to make sure that that person is comfortable and not in any pain. Apart from that, I hope the chat is open now, because it seems like people are able to at least let us know that
Yeah,
it's
maybe put the Q&A instead of the chat. Put your comments on the Q&A icon at the bottom.
okay.
Yeah.
Great. Yeah. So my next slide is a bit of a more of a textbook definition of what that looks like. Yeah. And then, yes, Robert, yeah, absolutely. Patient comfort, last stage of life, end of life care, and all it entails. Yeah. So I think everyone is pretty much on the same page when it comes to palliative care. And palliative care, this is an overview of one definition that I have here. It helps patients and families to achieve the best possible quality of life right up until the end of life. So, from the beginning of the dementia journey all the way until the end of life. And sometimes palliative care sometimes it's used interchangeably with end of life care. There are some nuances or differences between the two, and I consider palliative care something that we should be thinking about even up to the early diagnosis of someone living with dementia, because ultimately we are going to make decisions to ensure that we're supporting their quality of life, maximizing their independence as much as possible, recognizing them as, dignified individuals. And end of life care, I find that this is more so towards the perhaps last few months or a few weeks towards the final stages of when a person reaches that end. And it's also throughout palliative care or end of life care, it's often a main focus on comfort. So I'm really glad that I saw lots of people writing in that comfort is an important part of that. There's also a palliative approach, and this is somewhat newer. Sometimes we'll say a palliative approach to care. And this is where we're thinking about every decision that we make, everything we present to families and people living with dementia, that in the end, it's going to be beneficial for them and that there is likelihood of a good outcome based on what we recommend as well. Yeah. Okay. So some of the decisions at the end or palliative care or decisions you might come across throughout the journey. The first type of goals of care, and we have it categorized as 3 broad categories, but there are often overlaps or it's used interchangeably. But the first type of treatment would be the goal of care where it's life prolonging. This is if someone was to require, surgery or whatnot for hip surgery, or if they had a fall and they need to fix a fracture, we want to fix that issue so that that person can have a long quality of life. But it's not to say that that can also be a part of comfort as well if that person needs to have that done because they're in so much pain. So there's overlaps between the 3 categories, but what full treatment really looks like is that we're doing everything to extend that person's life so that they could live a full life as long as possible, a good quality of life. And this is definitely ideal, especially in the early stages of dementia, where we want to make sure that the person is we're maximizing their strengths, making sure that they're doing, everything they can for themselves as much as possible and supporting and encouraging them. And also, monitoring their goals and making sure we're helping them to meet their needs. In the quality of life and life prolongation stage, this is where the goal of care is still life prolongation, but it's also comfort. So we want to make sure that what we're presenting is ensuring that they're comfortable. We're making decisions to, reduce pain so that they can have a good quality of life, live a long life and not be in any pain. We want to make sure that they're presented with stimulating activities or active engagement so that they are they feel like they're still part of that circle of care, or that families and friends can still have these opportunities for socialization. So when we think of comfort, physical comfort is a really important one, but there's also different types of comfort that we should be addressing as well. So the mental health needs, social needs, psychological needs. We want to make sure that person is not in any distress. When we get to comfort care, this is where we're really focusing on more of that quality of life, enhancing that in different ways. If someone is not able to verbally communicate anymore, perhaps we can find other ways to connect with them through music. Therapeutic activities or touch or massages. There's different interventions and programs that can also help family members connect with their loved ones when trying to enhance their quality in life and comfort, whether they're in at any stage. It's just a matter of tailoring and adapting, and also tailoring to different cultures. When we're presenting music or providing snacks and beverages, making sure that it resonates with the person's culture and also with what family members are used to seeing as well. And in comfort care, you'll see that life prolongation is no longer included under that category. That's because that is when we're at a point where it doesn't seem like it is possible to prolong someone's life any further. So we're more interested in maximizing the time that we have and making sure that person is comfortable throughout the prolongation. So that's where you'll see some different treatments come off. Perhaps there's a reduction in medications that are no longer necessary, so that that person, they don't have to take 20 pills a day or something like that. Only the ones that are absolutely necessary for their medical comorbidities. And the palliative care I have here, it really should be integrated with all types of care, and it's very active care. It's not that we're giving up on someone. It's not that we're looking forward to the end. It's really we're trying to make sure that everything, flows nicely and that we're prepared for whatever happens. And we should really be thinking of palliative care even at the life prolonging stage when we're thinking about that early diagnosis, that early treatment. What kinds of things should we have in place? What kinds of discussions should we have with their family members, so that we know what their wishes are. So if the time comes, we're prepared to make those decisions on their behalf, and we're making sure that we're respecting their wishes and upholding their dignity as well. Yeah. So with quality of life and life prolongation, as mentioned, we're really trying to maintain that person's current health status. We want to make sure that we prevent any further decline in that person as much as possible and treat reversible conditions. If it's a pneumonia or they have different urinary tract infections, we can treat that so that they're comfortable and not in any pain or not experiencing any changes in mood or behaviors. It can also include medication. So we still want to treat the high blood pressures, or if someone has diabetes, we still want to make sure that they're provided with insulin so that they can still have the quality of life that they require and can still manage their meals as needed. And we also want to set that, if someone has a fractured hip or have broken bones, we also want to have active interventions there, whether it's surgery or rest, to make sure that they are not in any pain, and so that person can get back to their current baseline. You may also find that certain treatments can be selected, such as CPR, or sometime or but not others. So that's where you'll think about, is it worth it to do these chest compressions, which could provide some benefits, but also could lead to further harms. And there's possibility of breaking ribs during compressions and things like that. And I should also mention before we go any further, this is a very sensitive topic. So I'm hoping, after today that you do have someone that you could talk to about this. You have some resources to reach out to as well. And if anything, I hope that this is, something to help you to think about, to prepare, and to provide some information. I think with having more information and preparation, that kind of helps people when they do come across these different journeys or different milestones. So just something to think about as well. And if you need to take a break for whatever reason, please feel free to do that as well. So moving on to the comfort care, the goals of care being more of quality of life and comfort and no longer life prolongation. This is where we really want to make sure that we are only providing the treatments or interventions that are absolutely necessary for this person, not to prolong their life, but to ensure, again, that they're comfortable. And these could be, if death is near, perhaps we're not intervening if we do come across our family member who is in their, they've slept overnight and we wake up and we find that they have passed, and we will just go on and do our calls, and next few slides I'll discuss what that would look like at home. In long-term care, if perhaps a healthcare provider or a nurse was to come across someone who has stopped breathing and there was orders for do not resuscitate or allow natural death, in that case, then that nurse will not intervene. But this doesn't mean that if someone's having trouble breathing, that you shouldn't intervene. That because that's part of quality of life and comfort too. So there are things that people can still do in long-term care. For example, nurses could provide oxygen for that person. If they need a certain medication to help with that acute episode, there are still things that we should be doing even in that quality of life and comfort care stage. And in this stage, pain is control is an absolute priority. We know that people living with dementia, especially those who are in long-term care, pain is it's very prevalent in those kinds of settings. And people living with dementia, especially when they're more in the advanced stages, they're not able to communicate to us that they're in pain. So they're communicating in other ways besides verbally. So they might be grimacing or moaning. They might even be restless or upset, or even starting to refuse meals because they are in so much pain. So it's really important to recognize this, especially in this final, the third stage. I wouldn't say it's final, but it's the stage where we're really focusing on that comfort. Spiritual support is something that emotional and spiritual support, sometimes that is overlooked because we're so focused on making sure that physical needs are being met, that they're being cared for, that they're being they have the nutrition that they need, that they have the activities. But sometimes we forget about the emotional and spiritual sides of things, and especially in the comfort care stage where people are approaching that end of life, they really need this, I think, more than ever. They really need to be supported with families and friends, have opportunities more so for socialization, storytelling, having these positive conversations, even if it's one-sided, even if the person is no longer able to communicate verbally. Family members and friends can often share these stories and use images, photos, videos to stimulate conversations and just reminisce on some of the important memories that you've had. In long-term care or even at home settings, lots of people practice different faiths. So it's really important to recognize, provide that comfort. Is there a pastor? Is there a chaplain, spiritual care support person that could come in and provide that comfort for that person, not necessarily at the end of life, but throughout the dementia journey, so that they have some hope, and also feel that they are at ease and can discuss with someone else of their faith. And ultimately, comfort care, it's about allowing a natural death, letting life in some way take its toll and get to that next stage, intervening as little as possible, yet still trying to fix the acute issues as much as we can so that they're not in any distress as they reach this end journey. Some things to think about as well is that, death is not something that people really like to talk about. Oftentimes in society, we're not as prepared as we should be in planning for, wills and advance directives. And oftentimes we're doing this when the death has occurred, and this is where people are often scrambling, or they're trying to have the discussion with all family members to think, what would our parents would have wanted, or what would our children would have wanted. So we're still a long way of really having these open discussions, and there's lots of initiatives that are put in place to help people feel more comfortable in having these discussions earlier. And I absolutely can appreciate that it's also the timing of when these discussions should occur as well. In the early stage of when someone is diagnosed with dementia, it can very much be very overwhelming, and it's perhaps not the ideal time to start thinking about, what palliative care looks like or what we would want. But it doesn't necessarily need to be so intricate or specific to those end stages. We could simply start thinking about what is important to the person living with dementia, what kind of, what kinds of things do they want to still be able to do, what's important to them, who is important to them, what kinds of activities could we provide, what are their wishes. If something was to happen, have you had discussions about whether you would like intensive treatments or CPR done or things like that done, or is the person more at ease and wanting to simply be comfortable in quality of life without any excessive interventions or transfer to hospitals or things like that? Death is also a normal stage of life, and it's something that is very, very hard for families and friends to cope with. Yet it's something that is so common and that happens so often. Yet every time that it does happen, we still feel the big loss, and we never feel completely prepared. And there's always new challenges or new hurdles that do come up around the corner. Some things to think about is, think about, have you thought what death may look like for your family member or friend who's living with dementia? Have you thought about, what kinds of things to expect? Are you prepared to see some of these things in the person living with dementia? And also, have you thought about what to do if death has occurred? Have you thought about, next steps or who you should be contacting, or, what kinds of arrangements would be made, or how soon would these need to happen? And also, have you thought about yourself in terms of whether you would be ready for if death does happen, whether it's suddenly or gradually, or perhaps you've had a few weeks to think about it when you notice your family member or friend seem to be approaching more of the end of life stage. So have you thought about these kinds of arrangements or how fast this can happen, and whether or not this is something that you've discussed with your other family members and friends, and whether you're really, ready for what this could look like. This slide's a little bit heavier, so I'll take some time. It's really the final days and moments of what to expect. And you might have noticed, if your family member or friend has already progressed towards more of the advanced stages, you've probably noticed some changes happening gradually already. So this slide is more so about those final months or even the final month or days or weeks. And it really looks different for everyone, and you might not see everything happening. If you do see some things, it could be as a result of other conditions as well, not necessarily an indication that the person is approaching end of life. So for example, if we notice that people are having a decreased intake, well, that's often a normal change in people living with dementia, that they're not, taking in as much, or their appetite has changed. So it doesn't necessarily mean that they've approached the end of life care. So just being mindful of those types of situations. But what to expect in those final days and moments, I'm thinking perhaps more like within that week or within those days, is that we'll see some changes in circulation in the body. So their circulation has decreased quite a bit. It's quite pronounced. You might feel that the extremities, so hands and feet, might be very, very cool to touch. You might notice some changes in color. So the person might be more pale in the extremities. When it's really perhaps even like nearer the end of life, the day or two or even the week before death, you might even notice some modeling happening where you see the skin tone changes and there's some textures. It looks somewhat like marble, where you do see some more pronouncement of these pale blots on the skin. You might also notice that the skin is also more prone to breakdown. So the skin is more fragile. They're more at risk at this stage also for pressure ulcers, because at this point they might be more so spending more time in bed. They might not be alert. They might not be able to be sitting up in a chair or do their activities as they used to. So the skin becomes very thin, and because they're not drinking and eating as much at this stage, there's also risk for dehydration. They might bruise easily as well. At this point, this is where physicians or healthcare practitioners will probably not order as much blood work to try to rule out what's going on, because this is something that's expected. And this is where healthcare teams will have a discussion with you to perhaps reduce more of the interventions and ensure that they put in place protocols to make that person comfortable as much as possible. So it's really also important in any setting, whether they're at home, long-term care, or in a hospital setting, to ensure that we're repositioning the person at this final stage. So making sure that they're being turned every 1 to 2 hours from side to side, making sure that we also use pillows as much as possible. And in my practice, I would use, 5 or 6 different pillows so that we are, so that the person is comfortable and that their knees are not touching together. And because there's, risk for even further decrease in weight loss, and there's lots of bony prominences that can also be happening at this stage. So we want to make sure that their shoulders are well supported, and that no new wounds are happening at this stage, which could cause further pain and discomfort and also lead to infections. We also want to make sure that this person is, moisturized as much as possible, especially if they're not eating and drinking as much. They're really prone to having dry skin, so using moisturizers. And it's actually a nice way to also provide massages and touch, providing those touch activities at the same time to connect with family members, making sure we're moisturizing their hands, their feet, their faces, putting, chapstick on their lips as well, because their lips can get very dry if they're mouth breathing a lot. That is another issue. They might also experience the dry mouth. So sometimes there's mouth swabs if they're not able to swallow, that we could dip in water and moisturize their mouth. There's also artificial saliva spray that could also be ordered by the physician or nurse practitioner so that the person's oral mucosa stays moist. And despite some of these changes happening where there is quite a bit of dryness, there's still a possible buildup of secretions, especially in the chest area or the lungs, because person is often lying down. They're not able to, cough up if they are having, lots of buildup of fluid in their lungs. So this is where you might hear sometimes a bit of rattling, or there's and and it sounds like there might be like gurgling a bit, and it's more distressing, I would say, to family members and friends than it is to the person who is experiencing it, because they might, at this point, they might be more lethargic and might not be aware of that happening. But there are things that physicians and nurse practitioners can also order. So there's medications, and one is scopolamine that could be used to reduce some of these secretions. But we also have to be mindful that this person is still at risk for having dehydration. So being aware of also the skincare that's needed along with that. The person might be sleeping more than usual. There might be very few periods of alertness at this point where you'll notice that they're missing meals more than usual. Perhaps they haven't eaten for 2 or 3 days. The longer they haven't eaten, the harder it will be for them to swallow. Oftentimes, family members and friends are very worried that this person has not eaten in many days or has not drunk in any days, and they'll try to. So food at this point is really for comfort if they're able to swallow appropriately and it won't cause any further distress. But it's also, we can also, even though they're not having that nutritional intake, and that's okay, because that's actually a normal process of the body kind of telling you that they are at a different stage, that the person's at the different stage. So the body systems and the needs might change at this point. The person might experience some periods of, I don't have it on my slides, but there's some changes in respirations as well. So the person might be breathing heavily at one point. They might stop breathing. It's apnea, where they'll stop breathing for a little bit, for a short period. And this is where family members or friends and healthcare providers are worried. And they'll worry that, oh, has the person passed already? But then they start breathing again. So you'll see these rhythmic changes, and it's not very scheduled, and it could happen periodically. It could happen throughout the night where the breathing patterns have changed. Near the end of life as well, the heart rate increases quite a bit. So you'll notice that the person's heart is trying to work harder, but as they approach the more final days, or even final hours, the heart rate actually decreases instead of increases. With regards to restlessness, there's a number of reasons why people living with dementia at the end of the final days and moments are experiencing restlessness. There might be because of pain. So there's lots of interventions that can be provided. Even if the person is no longer able to swallow pain medications, they could be provided pain medications through something called a subcutaneous butterfly device. And it's a little device that's inserted under a fatty tissue, such as the back of the arms or upper thighs, or even the stomach, and medications can be injected frequently through this device. So the needle doesn't stay inside of the body, it's retracted, and there's just a flexible tube that stays within underneath the fatty tissue under the body. And it's changed every so often. And if it falls out, obviously it'll be changed as well. But medications are delivered this way so that the person doesn't have to receive multiple injections every 2 hours. So that way they're just receiving medications through their butterfly. So some of the common pain medications are most likely narcotics that they'll be receiving at this point. So there's morphine, there's hydromorphone or Dilaudid. So those kinds of medications can be provided scheduled. And most often there are protocols in place for these final days and moments where physicians will actually put in place and order these medications, whether or not the person it looks like they're experiencing pain. So automatically they're going to order pain medications. They might start gradually with longer doses every 4 hours, and as needed, they might schedule it every 2 hours. And there's also opportunities for breakthrough pain medication. So if every 2 hours or every 4 hours is not enough, there can be additional doses given in between there. There's also medications that can be provided for agitation or if there's restlessness. So some of them might be Ativan or Midazolam, and again, that could be inserted through a butterfly device, a separate one for the pain medication. So people living with dementia at the end stage, they can have multiple butterflies for different medications because we do not want to mix the different medications for each site. So it should be clearly labeled. And with that medication, that can help when they're experiencing some restlessness or they're having trouble sleeping, or if you notice that they're fidgeting quite a bit as well. So these are some things that are quite common that you might see happening in home care. It might look a little bit different, but through the LIN, I believe there are, through home care organizations, there should be home care services and palliative care teams available to you if you are at home and caring for your family member or friend there. So they can also provide recommendations, help you in gaining mechanical beds and equipment that's needed to keep that person comfortable near the end of life. When death has occurred in hospital settings, long-term care settings, or even at home, this might look quite different. We'll start with hospital, long-term care settings, or even a healthcare setting in general. You'll be allowed to spend time with your family or member or friend after death takes place. The time allowed, however, varies by setting. So in long-term care, it could be perhaps 24 hours that you'll be able to it'll take to spend that time or have that room for yourself. In hospital, sometimes depending on the setting, sometimes there's a need to have new patients come in. So it might be a little bit more rushed. It could be 4 hours or so. It's very difficult for family members who live far away as well. So and also, it's really important to let the long-term care home and hospital settings know that you would like to be notified if someone was to pass throughout the night. That way they can call you and you can come, right away, even if it's throughout the night. Some families they would like that to be done, and others have, they're comfortable in letting the hospital staff, do what they have to do when the person has passed. And it's also important to identify the contact person who would be best to share this sudden news. Maybe it's not a elderly spouse, for example. Maybe it's the child of a family member who might be more appropriate to take on that news and then pass that on to others in the family. Usually staff are quite familiar with the process of transferring the person who has passed to a funeral home. You don't usually tend to need to inform them which funeral home has been arranged, and they will connect with you on that. The physician will also provide a medical certificate, and this is important for you so that you're able to register the death as well. At home, it looks a little bit different. So there's a lot of things that are put on you to take the initiation when death has occurred. So you'll need to contact your family physician. You'll also need to contact a funeral home to arrange the transfer of that person to the home as well. The days after death has occurred, you'll be very busy in notifying family and friends, letting people know, that this person has passed. It's really important for you to find ways to accept help from others. Perhaps, you start calling one person and that person can offer to call others in your circle of family and friends. So accept help as much as possible based on your own comfort level, even if it's asking or having someone to help with making the calls or meal arrangements, or even having that social or emotional support. So if someone has passed away in a long-term care or hospital setting, you might be asked to collect belongings in a very small amount of time, sometimes within 24 hours. This could even be a smaller amount of time. It does seem a bit cold at times because, they're packing everything, and perhaps by the time you arrived in the room, everything was already bagged. So just be prepared for this. And it is, it's overwhelming as well because of the changes that are happening in that room no longer looking like your family member or friend's room. So just some things to think about. And the reason why they're doing this perhaps is because there's long wait lists for long-term care, and in hospital settings they're often looking to have people have beds on units. So this could happen quite quickly. If things exist too, if there's a palliative care suite in hospital settings, that is ultimately ideal if that could be offered to you and your family member. That way you can spend more time. You can even spend time overnight. Some long-term care homes also have palliative care rooms, or they'll have comfortable beds or chairs that you could also use to stay overnight with your family member or friend if they're at the end of life stage. So consider asking what options are available to you, and what are the visiting hours? Could you stay overnight? And what does that look like? At this stage, it is ideal for staff to check in with you and also people living with dementia more often, so that they're making sure that you're comfortable and that they're comfortable. If you prefer not to be disturbed throughout the night, and because you're already visiting, you might let staff know that rounding is not as necessary for you and your family member. Or you can also, or staff might just understand that because you're visiting as not to disturb you, they might visit the room less throughout the shift as well. Some other further considerations to think about is, what would you like the final days and moments of your family member or friend to look like? And have you shared this with anyone? Have you actually verbalized or talked this through with people that you trust with your most intimate stories? And what would the person living with dementia have wanted? Have you ever had the opportunity to talk about this before they were diagnosed with dementia, or even during the early diagnosis stage? And have spiritual needs been considered throughout the journey? So, has last rites been offered to this person? Is this something that they would have wanted? What kinds of cultural practices are put in place when someone approaches the end of life? And how can we connect with those resources so that that could be put in place when the time does come? I'll go through a bit of the common care decisions at the end of life, even though there are quite a few decisions to make. I've listed the most common ones, perhaps. And this is not to say that, well, hopefully that healthcare team will approach you and ask you, do you want this done? Do you want that done? Or do you not want these things done? It's really important to have a fulsome conversation and be informed about the choices. So it's not just a matter of yes or no. It's, what are the risks? What are the benefits? And if possible, making that unique to the person living with dementia. So not just general stats, but just based on the comorbidities, and the outcomes or the test results. What are the benefits in that case for that person? So making that very individualized. So the first common decision that you've probably come across is cardiopulmonary resuscitation, or CPR. So this is staff, especially in long-term care, will ask you whether or not you would like CPR done, and they'll often do this on admission. They'll have a sheet, perhaps a checklist, to ask what are your thoughts about transferred to the hospital if something was to happen, or CPR, or if it's DNR order that you would wish. So there's different levels of care, and every home does this differently. In a home setting, it's also wise to have some sort of advanced directive or order in place as well if someone had that put in place before the diagnosis of dementia. I've heard from a family member that they actually put this up on their fridge. So if the paramedic was to come, they have access to the CPR form right away, and they could show them that actually we have a DNR order in place. So if we are opting for CPR, there's some important considerations to think about as well. Is that it could be painful and quite traumatic for the person living with dementia if they were to receive CPR. As mentioned earlier, there's risk for breaking ribs. There's a need for perhaps transferring to the intensive care unit afterwards. And it's not always guaranteed that a positive outcome could happen. There could also be further decline if they do survive the CPR event where there might be even more changes in cognition or memory or ability to complete activities independently. And CPR may not necessarily prolong life as well. It's especially if they are already living with a progressive illness. And it's often not recommended by many experts when people already have a low quality of life, depending on the trajectory or their stage that they're at. So you'll see people talk about DNR. There's also allow natural death. And if they have this order in place, it really tells the person intervening or medical professionals that they're not to intervene if the person stops breathing or their heartbeat stops in that scenario. With regards to feeding tubes, it's usually used for short-term use, and there has to be a really fulsome discussion about this as well. Sometimes it can be suggested if a person has difficulty eating or swallowing, if it's due to a short-term condition or it's as a result of surgery, but it doesn't necessarily show to prove, it hasn't been proven to benefit or extend the life or even the quality of the life of a person who has a feeding tube. There's also risk of infections at the site of insertion, so there's a need for close monitoring. There's also discomfort to the person, so depending on how often they're receiving the nutrition through the feeding tube, there's a risk of bloating. The dietitian would have to keep a close eye on the rate that the feed pump is set up at. So it's really important to talk to the healthcare team about the specific plans for feeding tubes. How long will it be put in place, for what use, and the types of nutritional fluids that are also being administered, and the timing. So what time should it be administered? Is it overnight or is it during the day? Perhaps during the day they're very active and they might not want to be connected to a tube throughout the day. IV hydration or intravenous hydration is another one that common care decision that you might have to make. So if people are not able to take medications orally, they might need to use an IV pump that goes, and it's a liquid that's administered through the vein. But also note that the lack of hydration is often a normal part of the dying process. So if we do opt for the IV hydration, this can actually draw out or extend that dying process for weeks, even if that person hasn't been eating or drinking. So IV hydration should really be used with specific goals and for short periods of time. So if it's for medications or antibiotics, if it's for whatever other reasons or treatment that they do require, if it's because of their electrolyte imbalances, and once that's done, that could be removed, but it's not to prolong someone's life in that scenario. So it's more to be used with treatment. One thing to notice as well, people living with dementia, sometimes they don't like to be attached to tubes or have all of these feeding tubes or intravenous hydration IV tubes. So you might see them trying to pull out tubes or IV tubes as well. And I sometimes find that this is kind of a natural process of them telling us that they really don't want anything further done. And it's irritating, it's uncomfortable. So they're trying to remove that. So it's harder for families sometimes, I find, to accept that the person has, removed their IV or removed their feeding tubes because they no longer want that in place. Antibiotics is another type of medications, and this can also be provided through the end of life as well. So it could be administered as a pill format. Some of them can be crushed. It can also be administered through a vein, and it's most often prescribed for infections that do have a good outcome that could treat them, but it might not necessarily improve the person's condition at the end of life stage as well. So you might notice that these kinds of medications are taken off after we notice that it doesn't have much of an effect in treating the pneumonia anymore or the urinary tract infections. And it's best to reduce the medications and just keep the person comfortable as much as possible. With regards to reflecting on some of these choices, something to keep in mind is, have you thought about, what your family member would have wanted or what would fit their wishes or their needs? And have you thought about some of these or even heard about these medical care decisions and had a discussion with your healthcare team? The last item I wanted to speak to you about as well is ambiguous loss and grief in dementia. And the Alzheimer's Society of Canada has a really great publication, a little pamphlet on this as well. And they're talking about how you might experience grief even before the person has passed. You might even experience this as soon as the diagnosis of dementia has been provided for your family member or friend. So even though your family member or friend is still with you, things have changed so much that they're not able to respond or react in the same way. So you start to grieve some of these usual moments, what things used to look like, what you're used to be able to do with that person. But regardless of this, people living with dementia, they're still the same person. And it's just a matter of finding different ways of connecting and trying to find ways to adapt to these changes, accepting these changes as much as you can, um, and still find ways to, and there's still lots of ways that you really can communicate, even though it's not verbally on the part of the person living with dementia. So anticipatory grief really is a natural process, and you'll feel some changes when you do experience that first diagnosis all the way up into the end. You might deny the things happening because your loved one still looks really, really the same. They still seem like the same person. They're able to do the same things. You might feel guilt in not being able to, you wish you would have taken that last trip to Hawaii with your family member and now you can't. There might be some angers and frustration as well as to, why is this happening to us? And you might even anticipate that it's the adjustments. It's just a lot to adjust, and it's important to have family members and friends to be around with when you are feeling these kinds of emotions. And grief following death can actually be experienced quite differently than the anticipatory grief. And the next slide, I'll talk about some of the feelings of grief might actually be more of a relief because you're feeling that, the death has relieved some of that suffering for that person who's been experiencing so much and that you've been experiencing so much along the journey. So when that end of life stage comes around, you might actually feel like there is a little bit of hope that there is a hope end to that suffering for that person. Sometimes people might feel that it's weak or it's unacceptable to wish for death, but family member and friends, they're not wishing for death really ideally or doing anything intentional. They're just wanting that person to have an end to that suffering. So it's really common and normal to have these kinds of thoughts, and be reassured that this time will not go on forever, and that things will change and that you'll also see some positive moments throughout the journey as well. So some things to hope for in the later stages is really hoping that their pain is managed, that people living with dementia and yourselves, you have that dignity intact and you have that supported, that the entire family will be okay near the end, and that you could spend time together, whether that's outside or when visiting, and hoping that they'll be remembered well for all of the things that they've done in their lives and all of the people they've supported and been a part of, in their own lives as well. So remembering what their careers used to be, remembering that they're still a parent, they're still a child, a spouse or brother, and also remembering that you can still find peace together, and that's something to hope for, is to have that comfort and quality of life at the end and be at ease with the changes and accept things as they are. Some of the strategies to cope with the changes, it's really important to put some things in place and to think about self-care for yourself. So seek support from family members, friends, community, Alzheimer Society, this group as well, and the Alzheimer group here, it would be really good to connect with different events, having these discussions, in-person events, virtual events, whatever suits your needs. It's really important to express your feelings in creative ways as well, whether that's through music, creating or listening to music, dance, art, painting, drawing, or writing stories. Really important to seek information about dementia and what to expect. So, preparation is really key to help you with when the time comes. So trying to find out as much as you can, as much as you can handle, as well, and then discuss the values and wishes of people living with dementia with healthcare providers so that they're aware of what you both would have wanted, and reflect on what you are doing well. So consider starting a journal, looking after your own needs as well, and thinking about how you can ensure that you are putting in place your health, social, and hobbies and prioritizing those. I have a few resources here. The Alzheimer's Society of Canada has lots of information about what the end of life care might look like. The Canadian Virtual Hospice as well has some great resources. And even in the UK, there's quite a bit on the Alzheimer's website as well. And then there's also some things to help you think about in making these tough decisions. So the Ottawa Personal Decision Guide, there's the Conversation Project, and also Advanced Care Planning Canada has some great resources. Yeah, so I'm gonna stop here and thank you so much for your attention here. I'm looking forward to hearing more from you and answering some questions in the Q&A box. I'll stop my share.
Yeah. So there's a question here from Suzanne. What to do if what your loved one wants at end of life, see family members overseas that are no longer living, isn't possible?
Okay, so is Suzanne, this question is if you have family members who are away and they're not able to visit, but the person living with dementia wants them to be able to come. Is that how I'm
I
interpreting it?
think so. Yeah, me too. Yeah.
Yeah, so yeah, absolutely, and it's definitely challenging when we're, there's everyone is living in different places. So I would suggest, now that we have so much technology, if it's possible to do, virtual calls, phone calls, or even bringing photos of that person or videos so that we could, share stories of that person, or so that we can remember some of the memories that you've experienced together when they were together, and living far away if they're not able to travel to visit.
Another question, why would life prolongation be part of palliative care?
Yeah, so that's a really good point. So life prolongation, especially when it's a person who has a chronic illness where there is no cure, especially with dementia, I would say we should start thinking about palliative care, even in life prolongation, so that we're thinking about the future, about, whether these interventions are going to be helpful in the end. So oftentimes people will, in early stages of dementia, we're still thinking about all of the treatments that they can do and know that this is still likely that they still have a good 10 or 8 years ahead of them. So that's why we can still think about palliative care, but it's thought a little bit differently. But ultimately, we're palliative care in this stage is more for comfort, quality of life, and trying to extend their life if we can, so we can have more of those years and they can have more of those years together.
Okay. So I just want to clarify actually, Suzanne, the first question she wanted to, her father wants to see people that are no longer living. So I think this is
Oh, okay.
yeah, yeah.
Yeah, okay. So that, yeah, absolutely. And sometimes yeah, so that's end of life or once they're at the later stages, they might be having some visual hallucinations or delusions or seeing things that are not there. And that's also a normal process as well. So if they're starting to see or wanting to see family members who are no longer living, I would just say, and sometimes it's a little bit of a white lie, but it provides that comfort, just saying that they're not able to travel right now. You could show some photos or videos, or if you're able to gently redirect the conversation, if not being able to see that family member causes them distress, perhaps gently talking about others that they're still able to see, or talking about, oh, well, this family member wants to come and see you, or your cousin wants to come and see you, so that they have someone else that they could look forward to seeing.
Yeah. I think that that's it, Dr. Hughes. I think the resources, the videos is being recorded, and we are hoping that we could like post this in our how do you say this, in our YouTube channel. I think you, the participants, you will be there will be a link that would be emailed to you to let you know that it's ready for viewing, and then there will also be a survey that will be emailed to you. So if you could like actually complete and fill the form, that would be really helpful for us. Um, Dr. Hughes, thank you very much for your lovely presentation and for enlightening us about like what's palliative care and what's end of life and what are the things that we need to take into consideration early on. Thank you very much for this presentation, and thank you for everyone who come in today. So the resources, uh, I think we will be able, if it's included in the video, so we will be able to post it
Yeah,
with
and
that.
I would be happy as well, Maravik, to just send us a separate page of the resources so that people
Oh,
can
okay.
actually click on the link afterwards, and you can share that. Yeah.
Yeah. So I just, okay. So everyone is saying thank you, and it was
Okay,
very
great.
informative. Okay. So thank you very much again, and have a lovely afternoon. Dr. Hughes, thank you very much again for this presentation.
Great. Thank you so much, everyone.